Yeah, Saiti, can we
Yes,
start the
yes,
webinar,
ma'am.
please?
We are live now. We are live now. First slide. So, good evening, esteemed faculty members and all the delegates. Thank you for joining. This is Sahiti on behalf of Shield Connect, welcoming you all for today's webinar organized by AMOGS Emergency Obstetrics Committee and Bangalore Societies of Obstetrics and Gynecology. It's my privilege to introduce the convener of today's webinar, Dr. Monica ma'am. Ma'am is the consultant obstetrician and gynecologist at Mangalore
Saiti,
Nursery.
it's okay.
Yes.
It's okay. Thank you so much, Saiti, for the beginning. I and Dr. Madan Kamre, sir, are the conveners for the program. Thank you, Rekha Madam, for allowing us to conduct this program with the Bangalore OBGYN Society. Saiti, before we begin, can we have the lamp lighting?
Sure, ma'am.
Yeah. We begin with the program with the blessings of Lord Saraswati and Lord Ganesha so that our movement is flawless, and then we will be starting with the inauguration program.
There is some issue with the
The
sound.
audio is not.
Audio is not coming.
Yeah. Thank you, Saiti. It is a proud privilege to introduce the convener for today's program, Dr. Sneha Buyar, Madam. She is the chairperson of the Emergency Obstetric Committee, AMOGS. Thank you, Kiran sir, for allowing us to conduct this program under the aegis of AMOGS. I would like to introduce Dr. Sneha Buyar, Madam. She has many firsts to her credits apart from the CV that has been displayed on the screen. She is the first national faculty from Yavatmal, the first fellow of ICOG, the first FOXY chairperson from Yavatmal, the first person to receive the National Individual Awards by FOXY and Unsung Hero SN Malhotra and Durusham Community Service Awards, the first to receive the State Award for Healthcare by the Government of Maharashtra. She is also the first to have more than 30 national publications and more than 300 talks in various conferences. Ma'am, we welcome you and we formally invite you to welcome all the delegates and our respected faculty members for today's 33rd episode of the Emergency Obstetric Committee webinar.
Yes. Thank you so much, Monica, for that very kind introduction. A very good evening to one and all. Myself, Dr. Sneha Buyar, as you heard, that I'm the chairperson of the AMOGS Emergency Obstetrics Committee. Welcome all of you, especially our respected President AMOGS, Dr. Kiran Kurtakoti, Secretary Dr. Bipin Pandit, immediate past President Dr. Pardesi, the Bangalore Obstetrics Society President Dr. Rekha Rajendra and Secretary Dr. Uma Devi. Of course, our guest of honor for today's program, Dr. Parag Biniwale, the ICOG chairperson, and Madam Sheila Manyachi, chairperson-elect of ICOG, all the esteemed faculties and delegates, a very good evening to all of you. As you know that just few decades ago, the maternal mortality was so high, 513, and then it came down to 300. But with the advent of institutional deliveries, and the widespread awareness about active management of labor, MMR has come down to 97, though few states like Northeast and some northern states still have it very high. We are proud that Maharashtra is 33 and still we have to work harder to achieve the SDG goal. So these various, we are organizing such academic sessions. Yes, maybe even the last 2 years as Medical Disorders Committee and these 2 years as Emergency Obstetric Committee. We're trying to make the sessions very, very practical, to achieve our goal to minimize the maternal as well as perinatal mortality rate. So for this, today we have the talk by Dr. Aruna Murlidhar, who will be speaking on the sudden maternal collapse, chaired by Dr. Rekha, Dr. Malini, who is a senior obstetrician, and Dr. Indukala. Panel discussion is moderated by me. And it is on the labor emergencies. We have Dr. Srimati Raman, Shailaja, Nalini, Dr. Satyavati, Rajni, and Dr. Srinivas as panelists, who will have valuable inputs. They will share their experience as well as evidence. So the program has been well coordinated by Dr. Monica Umbadan and Dr. Madan Kamre. And with this, I thank the AMOGS president and the entire team for giving us this opportunity. And may I now invite our the president of AMOGS, Dr. Kiran Kurtakoti, the multi-talented and multitasking personality, for his views. So over to you, Dr. Kiran, for your speech.
Well, thank you, Dr. Sneha, today's chief convener, my co-guests of honors, Dr. Parag Biniwale, Dr. Sheila Mane, today's conveners, Dr. Madan and Monica, a lot of friends in Bangalore that I can see. Rekha Madam is there, Dr. Malini, Dr. Srimati, and everyone. So, when it comes to Bangalore, or rather when it comes to Kasoga in general, okay, not only Bangalore, but only when it comes to Kasoga in general, there are very, very good fond memories of Bangalore as well as Kasoga, because that is the place where I was invited as one of the first speakers when I started my journey in Foxy. Bangalore was probably the first society who invited me to give a talk on medical termination of pregnancy. So always lots of love and affection to Bangalore as well as Kasoga. Lot of good friends. Sheila ji, you are there, and the kind of love and affection that we have. Dr. Thobi is also there. A lot of people are. So, well, coming to today's program, Sneha, I really must admire you, because I think this is the 33rd program. I know how much efforts it takes to organize one program. Now, this is the 33rd episode that you are doing. Fantastic work for AMOGS. And I really look forward to all the labor room emergencies and the other panel discussions that you would be conducting. So my best wishes to you also and to the entire program. Thank you once again. And I'm sure that this year, the 100th program also will be inaugurated by me. And at that time, I would request you to invite invite two chief guests. One is, of course, me, and the other is the president of Kasoga at that time. So it would be really a good thing for all of us to be there on the same dais, sharing the same platform. Thank you.
Sure. Thank you, Kiran. In fact, if you consider the last medical disorders 50 programs, and this is almost the 83rd program. So thank you so much. And may I request Madan, Dr. Madan, to introduce Dr. Rekha Rajendra Kumar for her welcome speech.
Yeah, Sahiti. Yeah, good evening, everyone. It's my pleasure to introduce Dr. Rekha Rajendra Kumar, ma'am. She is the gynecologist and IVF specialist. She is practicing for 33 years. Currently, she is the president of Bengaluru OBGYN Society, also organizing chairperson for many conferences, and she was chairperson for Ethics and Medical Legal Committee. Currently she is at Kasoga. Also South Zone Coordinator, Foxy Medical Disorders Committee. She has headed various committees and chairperson for many conferences. Also past member of Foxy Sexual Health Committee, Endocrinology Committee, etc. She has so many awards in her name. She is ex-PG teacher also. She had many original articles and cases and poster paper presentations. And I welcome you, ma'am, for this session.
Thank you, Dr. Madan. It's a nice program that we have been doing. Very happy to be associated with AMOGS. from Bangalore Society as well as a representative of Kasoga. It's a very precious moment for us, and we have also chosen good number of well qualified and well experienced BSOGians and contributed to this webinar. And we hope that we are going to do a great job here, especially in the panel discussion part. Thank you.
Yeah, thank you, ma'am. Yes, next CV, Dr. Malini.
Ma'am, can I request you to please introduce Dr. Parag Biniwale, sir, our guest of honor? Rekha, ma'am.
Yeah. Yes. Thank
Yes.
you. Yeah, thank you so much. Dr. Parag Biniwale is a very well-known figure, and sir is the senior consultant obstetrics and gynecologist from Pune. He's a PG teacher and unit head of Kamala Nehru Hospital. Chairman, he's ICOG chair now. This little bit old CV, I feel. So he's the chairman of ICOG current. Recently has taken over in AICOG, where we all evidence the glamour and the importance of that entire program. He's the president of Menopause Society Pune from 18 to 22, president of Pune Society from 22 to 23, national website coordinator of FOXY, and he has contributed a lot of articles and articles to the books and journals, a great academician and a good friend of mine. Thank you, Dr. Parag. Thanks for giving opportunity to introduce you, and please go ahead.
Yeah, thank you, Dr. Rekha. Good evening. I bring greetings from ICOG and of course AMOGS, of which I am the national coordinator. It's indeed a pleasure to share the same virtual dais with the president of AMOGS, a very dear friend, Dr. Kiran Kurtakoti, and Dr. Sheila Mane, who's the chairman-elect of ICOG. And Sheila, I'm in fact looking forward to next year's conference in Bengaluru, though my conference in Pune is yet to be over, because the ICOG is something which is close to everybody's heart. Sneha, congratulations to you for picking up Bengaluru Society. In fact, last week, thanks to Dr. Sheila Mane, we had a program on hypertensive disorders in pregnancy for doctors in the government sector. Because in Karnataka, there are so many mothers are dying because of hypertension and its consequences. So it is important that you, as the chairperson of AMOGS Emergency Obstetrics Committee, should take it up and involve seniors like Dr. Malini, Dr. Sheila, and everybody who's sitting here, and create programs in order to reduce maternal mortality. That would certainly have a great impact. My best wishes for the program and best wishes to you for your future endeavors. Thank you very much for inviting me.
Thank you. Thank you so much, Parag. Thank you, Dr. Kiran, for all your best wishes. I just take this opportunity to invite Madam Sheila Mane, whom I know since so many years. Saiti, can we have her CV just in short? Though we just have talked about her, that she's the chairperson-elect for ICOG and, of course, past president of Bangalore Society and past the organizing secretary for the Bangalore AICOG. She has so many awards and accolades to her credit. I'm sure Madam is the, Madam is the one who has worked at grassroots level for so many emergency obstetrics. We have attended the workshops also. So I'm sure your insights will be definitely helpful for all of us. So over to you, Madam Sheila Mane, for your speech.
Thank you, Sneha. And first of all, I would like to congratulate you and as a chairperson of AMOGS Practical Obstetric Committee. And it's nice to see that amalgamation of AMOGS as well as BSOG. And thank you, Dr. Kurtakoti, for this opportunity. Of course, I think as Sneha is a real academician and the topic she has always chosen close to everybody's heart, and she is a hardcore obstetrician. So after medical disorders, this emergency obstetric plays a very important role today, I think. And I can see the panel, everybody who is going to participate, they are all experts, and they have all managed all these emergencies, because now it has become very important, because we see more and more cases who come with more and more complications nowadays. Particularly, as Dr. Parag mentioned recently, we had a justosis program for the doctors from the public sector online certification course, because we found that hypertension is the leading cause of maternal mortality in Karnataka. And I think the scenario is changing everywhere now. So it is very important that I'm sure that all those scenarios will be discussed in a panel. And none other than Dr. Aruna, who is going to give a talk on how to manage the obstetric collapse. I think everybody must really, we have to learn it really, because, when something goes wrong, if we do not know how to do ABCD, because every minute counts there. So I really congratulate all of you, and thank you for inviting me once again. Thank you, Rekha, and all the BSOG members, and wish you all the best, Sneha, for your future endeavors. And we are all always with you. Thank you.
Thank you, madam. Thank you so much, all the esteemed dignitaries, all the faculties, and all the seniors here. Thank you so much, Madan and Monica, for coordinating this program so well. I just, after the God's blessings and of course the blessings of the dignitaries, we now move ahead with the academic session. I just take this opportunity to, this is actually my duty to organize the programs as a committee chairperson, but I'm contesting for the post of FOPSI Vice President from West Zone for the upcoming elections. So I request all of you not only support and vote, but also, lots of blessings from your side. Thank you so much. Over to you, Dr. Madan.
Thank you once again, all. Let us start our first session. The topic is sudden maternal collapse. For this, we have got the eminent speaker, Dr. Aruna Muralidhar, ma'am. May I have CV, please? The chairperson for this session are Dr. Rekha Rajendra Kumar. Just now, we have introduced ma'am. Dr. Malini, ma'am, who is the past president of Bengaluru OBGYN Society, and Dr. Indukala, ma'am, who is the past president of KSC AGOI. May I have the CV of Malini, ma'am? Yes, she is the professor in OBGYN, Saptagiri Institute of Medical Sciences at Bengaluru. She has a vast teaching experience and also for NBE students, UG, PG students, and she was the past president of Bengaluru OBGYN Society, organizing chairperson for ISOPAP 2014 at Bengaluru, joint organizing secretary of AICOG 19, also advisory committee member BSOG last year. She has so many awards in her name, so publications. I welcome ma'am.
Thank you for that introduction. Thank you.
Yes, the CV of Dr. Indukala ma'am. Yeah. She is the professor at Department of OBGYN, Saptagiri Institute of Medical Sciences, Bengaluru. She was the former professor and unit chief, Bangalore Medical College and Research Institute, currently working as senior consultant, Malathi Manipal Hospital, Bangalore. She has special interest in teaching infertility and preventive gynae-oncology. I welcome you, both ma'am, Dr. Malin ma'am, and Indukala ma'am, and Dr. Rekha ma'am. May I request Rekha ma'am to introduce our speaker, Dr. Aruna ma'am. Over to you.
Thank you, Dr. Madan. Thank you, Dr. Madan Kamble. It's a happy moment for me to introduce dear friend Aruna. Dr. Aruna Muralidhar is a senior consultant obstetrician and gynecologist who is practicing in Cloud9 Hospital as well as Sri Clinic Jayanagar. Women health activist and popular speaker in school, college, and corporate programs. She has special interest in maternal medicine, obstetric critical care, patient safety, adolescent health, and menopause care, and medical education. She has really deep, diversified interest in many of the maternal health fields. She's a past joint treasurer of our society. She's the director of public image Rotary E-Club. She's an active Rotarian of Bangalore. So she has a lot of awards to her credit. Thank you, Dr. Aruna, for accepting our invitation. And please go ahead with your talk.
Thank you so much, ma'am. Indeed, I must say, Guru Brahma, Guru Vishnu, Guru Devo Maheshwaraha, Guru Sakshat Parabrahma, Tasmai Shri Gurave Namaha. Madam Malini, Dr. Indukala, Dr. Rekha, Dr. Sheila, and everybody who have been teachers in various other ways. Thank you for this opportunity. Dr. Sneha, thank you so much for this opportunity, and you're doing such a wonderful job. Really hats off to you. With that, may I request a permission? Thank you. I couldn't there. So,
Thank you, Aruna, for accepting my invitation to give this talk and the right topic also.
Right person to speak the right topic.
thank you, madam. So, I'll just get my presentation on board. Yeah. I had put it, yeah. Yes. Can you all see the presentation?
No,
Not yet.
I think you have not shared the screen.
Ma'am, you have stopped sharing. You have stopped
Yeah.
sharing the screen again. Yeah.
First of all, why are you opening the mobile, Aruna?
Because my computer has gone off. Sorry. Yeah. How about now?
Yeah.
Sorry.
I'm not sure. Your CV is being shown.
No, not this. Yeah.
Yeah.
Just start off this with this. Yes.
Yeah,
Thank you very much once again. So my topic today is maternal collapse. And as you all rightly said, ultimately, whatever that initiating event may be, whether it's PPH or anaphylaxis or amniotic fluid embolism, whatever it may be, it's a collapse part that we all have to be extremely effective in managing. And that's when our maternal mortality will be coming down, right? I hope it's visible and I'm audible. Shall I go ahead?
Yes, perfect. No problem.
So I'll start off with the outline, obviously a little bit of background, the causes, a little bit of BLS and ALS, which all of us should be able to, in fact, sort of do refresher courses at a regular sort of frequency of 1 year. When I was training in UK, it was every 3 years that we would have to do something called advanced life support and obstetrics. So I think similar 3-yearly refresher courses. We talk a little bit about perimortem cesarean section, and very importantly, post-resuscitation care, because we need to understand that those women who've been resuscitated are also at a very high risk of mortality within the next 48 hours. And a little bit about clinical governance and medical legal aspects. As we all know, cardiac arrest, we do not have Indian statistics, and we always have to go by what is given in Western literature. But 1 in 30,000 pregnancies, and I'm sure in India it's much, much more than that. In the UK, it is said to be 2.78 per 100,000. In the US, it's about 8.5 per 100,000. And we know our mortality rates in India. And many maternal deaths occur from potentially treatable causes, potentially avoidable causes with suboptimal care. And maternal physiology, unfortunately, influences resuscitation, evaluation, and efforts, unlike somebody who's not pregnant. And obviously, as obstetricians, fetal outcome is directly related to the well-being of mother, but we must all remember that the mother is first. Mother is always our top priority, and fetus comes second. And many a times, mother resuscitated, the fetus is also resuscitated. Just a little bit about what exactly we're looking at in terms of various changes in pregnancy. Like we all know about increased weight gain, enlarged breasts, and a lower gastroesophageal tone, delayed gastric emptying, and this has implications on our resuscitation efforts by causing a difficult intubation scenario, increasing the risk of pulmonary aspiration risk. Antacid prophylaxis is absolutely necessary. There's a higher risk of aspiration and more importance for an earlier intubation. Similarly, an increased respiratory rate, we won't even recognize that she's sick. Many a times, we don't even look at the respiratory rate. But it's very important to reiterate to our nurses and our junior doctors that to identify a critically ill woman, it's not just the temperature and the pulse rate and the blood pressure, but it's also the respiratory rate. And that's the first sign of acidosis setting in. So at respiratory rate of about 25 in a pregnant lady is something which is considered to be abnormal. Similarly, there is diaphragmatic splinting. There's an increased oxygen demand. So a lady who is having PPH, who's PPHing, you can't just put it at 2 liters or 3 liters. You've got to put it at 10 liters of full oxygen. Also, we need to take in the fetus, which extracts about 25% of maternal oxygen. And hence, the mother in various ways is more prone for developing hypoxia quickly. Right? Similarly, circulation. We know about increased heart rate and cardiac output, and we know that almost about 25 to 35% is sequestrated by the uterus pressing on the inferior vena cava. So just a little bit of left lateral tilt increases that much of cardiac output. Similarly, peripheral vasodilatation, hence there's increased cardiopulmonary circulation demand. There's also a decrease in systemic vascular resistance, hence manual uterine displacement during a cardiac arrest becomes very, very important. So all these are some small elements wherein we have to be more cautious in dealing with somebody who is collapsed in a pregnant state. Coagulation matters, so thromboembolic complications are more common. Similarly, raised body index or preeclampsia, pre-existing comorbidities, again, we complicate the scenario. Now, right, we'll just go on there. So I do not want to delve into many other physiological things, but I'm just going to rush
screen is
through
not
these.
visible, Aruna.
No, not at all. Sorry?
Aruna, your screen is not visible.
No, your screen is very minimized, not visible.
Yeah.
Oh, sorry.
Some,
How
It
about
has
now?
gone to one corner. Just put it in the center.
All right, let me just do that again.
Yeah.
you could have shared your PPT to Sahiti and she could have shown that instead of the mobile.
Yes, that's true. Sorry, my apologies. How about now?
Slides are not seen yet. Yeah.
Yeah.
Now,
Yes.
Now it's okay?
Yes,
Yeah.
yes.
All right. So I just wanted to, these are all important slides, I agree. But all I was trying to understand, put across is that every single matter in the physiology of the mother would affect the bioavailability, the resuscitative efforts, and the reason why we do some things differently in a mother who's collapsed. So start off with the case because my main focus is on maternal collapse. Let's consider a case of sudden maternal collapse in the OT post-spinal during the uterine incision. Now, this lady who was talking and being really excited about the baby coming out suddenly is showing a bradycardia of about 30 or something on the monitor. She is not responding to you, and the anesthetist is obviously looking concerned. And you see that probably the field is almost like getting bloodless or something like that. So what are you going to do in such a scenario? This is what we're going to deal with, right? So what are the common causes of collapse in a pregnant lady? Pulmonary embolism, hemorrhage, sepsis, peripartum cardiomyopathy, stroke, preeclampsia, eclampsia, and anesthetic complications such as a failed intubation or a local anesthetic toxicity, aspiration, and a high neuraxial block, that is, a high spinal, for example. So when we come to a scenario, although we are all looking for causes, we still have to do the ABCDEF approach, which I'll come to in a little while. But the ABCDEFH of the causes of maternal collapse should come to our mind first. One is anesthetic. Of course, in trauma situations, a different matter. B is bleeding. So here in this scenario, she's probably not bleeding. Cardiovascular. So has she had an MI? Has she had an amniotic embolism or a pulmonary embolism? Drugs. Have you given her a drug which has caused an anaphylaxis? Is it embolism of any kind, air, amniotic fluid or air or whatever that may be, or a thrombus? Fever, sepsis, well, a straightforward elective cesarean section unlikely, and of course hypertension, which is preeclampsia. So in such a scenario, I'll come to this a little later. In this situation, we have to, and the anesthetist will obviously be thinking simultaneously. But is it like a high spinal? Is she hypertensive? Is there loss of airway? But in this case, it's a spinal anesthesia. So has she had anaphylaxis with which the entire mouth and the tongue has fallen back and she's swollen everywhere and is gasping for breath and has rhonchi? So all these have to be simultaneously looked at. Has she aspirated? is that respiratory depression? So they will look at the ETCO2 on their machines and find out what's happening. Or is it a local anesthetic systemic toxicity? And we will be, obviously the obstetricians, and in this scenario, we have the anesthetist to help us. So they will also have to think about the cardiovascular factors. And we also have to think about drugs, which can cause sudden cardiac maternal collapse, oxytocin, overdose, magnesium toxicity, a drug error, having given wrong blood group, illicit drugs, which most of the times we pick up the history, opioids, insulin, anaphylaxis, right? Embolism, as I told you already. But the physiological factors that we're looking at is the 4 H's, that is the hypoxia, hypovolemia, hyperkalemia, metabolic disorders, hypothermia, and of course, remember hypoglycemia, right? So the 4 H's along with the hypoglycemia makes it 5 H's, and the 4 T's, which is thromboembolism, toxicity, tension pneumothorax, more in cases of trauma, and even cardiac tamponade, which be more cases of trauma. Iatrogenic causes, again, we have to focus on the high neuraxial analgesia, as well as that usually causes bradycardia and severe hypotension. And we use adrenaline intravenously early in order to deal with that. So, sorry, I'm just going to have to go there. Right. So what do we do in such a scenario, right? We obviously have to call out the code blue. Right? The code blue not only involves the anesthetists there, but it also involves people who can help with porters, who can help with bloods, hematologists, a lab, as well as people who have trained in resuscitation and who know what to do in such a scenario, right? So we would check for the signs of, the life, ABC, unresponsive, not breathing, in a scenario where he's, collapsed in the room, perhaps. We call the code blue and the resuscitation team. We give her a left lateral tilt. Nowadays, earlier, we used to say Mrs. Tilt before we go and see her. That is completely tilting her 30 degrees. Nowadays, that is not required. All we have to do is a left uterine tilt in order to improve the cardiac output by about 25-30%, to improve the, inferior vena cava supply. And then we start the CPR at 30:2, that is about 100 per minute. And what we've been trained to do is, probably go by the song, the famous song, Chaya Chaya. So similar sort of rhythm. Chaya 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 Chaya. So that sort of rhythm, you follow that, and that will be approximately about 100 per minute. And typically the fists have to go about 5 to 6 centimeters deep into the chest. And then you would also do things like IV access, high flow oxygen, continuous chest compressions after intubation, if required, that is, treat the cause, and then depending on whether it's shockable or unshockable, you give the adrenaline, or consider amiodarone, atropine, and magnesium. I'll come to those details in a little while. So the immediate steps are A, B, C, D, E, F, G. Airway, breathing, circulation, disability in cases where, the Glasgow Coma Scale, for example, or neurological disability in strokes, exposure. For example, the intravenous cannula may be having still some drug for which has been having anaphylaxis, sepsis, fluids. F stands for fluids and G for glucose. So please do check the glucose as well. When the basic life support is happening, somebody must, inform the code blue team so that the advanced life support, including defibrillation, can be alerted. The high flow oxygen goes on. An early intubation must be considered in this scenario, especially. IV cannulae for electrolytes, urea, creatinine, a complete blood count, group and HOSAVE, blood sugar level, as well as to start the IV fluids. And also, sometimes, if it's a case of PPH, for example, we must be able to do a bedside ROTEM-guided management for management of major coagulopathy with various blood and blood products. So I'm just going to enlarge this. Is this visible to everyone?
Yeah. Yes.
So if this lady is unresponsive, you would activate the emergency response system. And the BLS response, that is a minimum of 3 additional staff and the code card. So every place in our labor ward in the OT will have a crash cart, and I think everyone should know where the crash cart is placed, and whether it has a defibrillator, and whether everybody who is been trained in the code blue team knows how to use the defibrillator, because many a times people are running like headless chicken and they wouldn't know how to place themselves in such a scenario and what to do. Then, of course, you check pulse, start the bag and mask, recheck the pulse, and then apply AED. If it is a shockable rhythm, the problem with the pregnancy is many a times in maternal collapse, it is not a shockable rhythm. It's a non-shockable rhythm, in which case we start CPR immediately for 2 minutes, check the rhythm for every 2 minutes. And if not shockable, you would then, start thinking about giving adrenaline every 2 minutes, right? So this is in general about the team management in cases of a cardiac arrest. But remember, there are other important steps to be done at the same time. For example, continuous electronic fetal monitoring where indicated, ECG and arterial blood gas samples, focus, especially to assess concealed hemorrhage, diagnose the cause of the collapse and modify management accordingly. In cases of massive obstetric hemorrhage, we activate the protocol because ultimately you have to resuscitate her fluid volume, notifying the blood bank, resuscitating with the blood products according to the ROTEM, and keeping the woman warm. Because the three things which can cause more mortality. One is hypothermia, one is acidosis, and one is the coagulation failure. So it's important to make sure that this doesn't happen, because all these three are a deadly triad of mortality. And of course, recording the fluid input and output and ensuring the next of kin is informed. Just go to the place where we're talking about the left uterine displacement. So if one person is doing it, all they have to do is place the two hands and pull the uterus towards the left side. Or if somebody is helping them with the resuscitation, they can use a single hand and push the uterus to the left side. So these are various ways of doing left uterine tilt. The way that the person must be positioned, I mean, when you're talking about advanced life support, there's a particular way that everybody has to stand in that place, because everybody has their own designated roles to play. In a pregnant woman, when you're doing the defibrillation, there are some rules. It's the same shock that we use for anybody else who's non-pregnant. But the application of the electrode pads are to be done below the breast, the left breast, and above the right breast. And this is if it is a biphasic defibrillator, we use 120 to 300 joules. The higher, the better. And if it's monophasic, it is 360 joules. So that remains the same. So once we've done the CPR, that is pushing hard, at least for 2 inches, that is 5 centimeters, you minimize the interruptions in compressions, avoid excessive ventilation, and change compressor every 2 minutes or sooner. So the compressor in the person, I mean. And if no advanced airway, 30:2 compression ventilation ratio. Then if it is a shockable rhythm, you apply the shock. But if it's a non-shockable rhythm, you directly go to the epinephrine or adrenaline, 1 milligram every 3 to 5 minutes. And if that's refractory, we then go to amiodarone, which is 300 milligrams bolus, and sometimes even lidocaine. The endotracheal intubation or even supraglottic advanced airway must be considered in a pregnant lady early, because that's one of the important things in case of pregnant ladies, because difficult intubation becomes a big problem if not done at the right time. Yeah. Now, when do we actually do peri-arrest or postpartum cesarean section? In a scenario which I talked about earlier, if within 4 minutes, if the lady has not had ROSC, which is return of spontaneous circulation, we start at 4 minutes of arrest and complete by 5 minutes. Where do we do this perimortem cesarean section or resuscitative hysterotomy? Anywhere, wherever the mother has collapsed, as long as we have some betadine to splash and a scalpel to slash, all is required is just these two. Moving to the OT is absolutely not necessary and will waste time. Splash and slash technique most comfortable to the operator. And the primary aim is to improve the chances of successful maternal resuscitation. It is not primarily to save the baby. And this is just some of the instruments required for a perimortem cesarean section. Anyway, it's going to be a bloodless field. All we have to do is our most convenient way and maybe a vertical through the uterus, deliver the baby, and then put some pads and close it, because it will be a bloodless field unless the circulation has returned. The standard guidelines are to pack the uterus, remove the lateral filt, and continue the CPR. At no situation must the CPR be interrupted when we are doing the PMCD. And afterwards, if she's returned to spontaneous circulation, then we repair anatomically when stable, and obviously keep her in the HDU and give her antibiotics and thromboprophylaxis as in whatever may be the situation. Why the 5-minute rule is also important to understand, because maternal apnea associated with rapid declines in arterial pH and PaCO2, and the fetus of an apneic and asystolic mother has less than 2 minutes of oxygen reserve, although that's not our priority. And after 4 minutes, without restoration of circulation, dramatic action must occur because the apnea can cause further severe acidosis. And these are all some, what we call proformas, which can be used in order to have a bird's eye view of what has happened, when the chest circumpressions were started, when was the code blue called, what was done about the airway, what was done about breathing, did we defibrillate, in which case, how many shocks have been given, when was the fetus extracted, and who were all attending to it. Post PMCD, it's important to understand that we should use uterotonics very cautiously, because that can again cause electrolyte imbalances. We have to have a low threshold to use compression sutures, especially in a post-resuscitation scenario. We don't want any further PPH because atonicity is more common. And there's a higher incidence of atonic PPH post PMCD, about 70%. And the conventional oxytocin 40 units per hour usage to manage atonic PPH has often led to recurrent cardiac arrest, so with poor outcome. So the use oxytocin may not be the best uterotonic to be used post PMCD. And survival was always found to be higher among women who were not moved from their place of collapse. So do it wherever it is. And chest compression may be compromised during transportation. That's another reason why we should do it wherever it's possible. What is the obstetric care that's required? Obviously, as senior staff, whenever possible, transfer must be, supervised. And if it's an antepartum hemorrhage, the fetus and the placenta should be delivered promptly to allow control of hemorrhage. In cases of massive abruption, cesarean section may occasionally be indicated, even if the fetus is dead, to allow rapid control of hemorrhage. So it's not necessary that we always have to achieve a vaginal delivery in cases of massive abruption. And in intravenous tranexamic acid, according to NICE in 2019, it has been proven to be significantly a great aid in reducing mortality. And Dr. Sheila Mane would vouch for that. Also, neuroradiologists and neurosurgeons should be involved in the care of pregnant women post-delivery or post-resuscitation in the HDU scenario. Now, what are the various ways of prevention of in-hospital cardiac arrest? Because the most important thing is identifying a critically ill patient. We shouldn't allow it to go to the stage of cardiac arrest. Most of the times there'll be signs like a dropping dropping blood pressure, or an increasing tachycardia or a bradycardia, or reducing saturations. So I think it's extremely important for all of us to start getting our nurses to use the MEOWS, or the Modified Early Obstetric Warning Score, which is a bird's eye view of understanding how the woman is doing over 24 hours with the pulse rate, the blood pressure, the saturations, the respiratory rate, the urine output, and even things like obstetric factors like the LICA, the color of the LICA, pain score, as well as the fetal heart rate. So if they're able to manage every postnatal lady, every lady who's had a normal delivery on the MEOWS chart, we can easily identify our acutely critical ill women and do the right sort of optimal care at the right time. So training staff with regular drills, empowering all the staff to call for help, and a clear policy for clinical response, structured communication tools, as well as reviewing our cardiac arrest events, debriefing ourselves, and giving recommendations as to what can be done is extremely important. So I think with that, I just wanted to talk a little bit about anaphylaxis, because this is a chart which is beautifully drafted by Resuscitation Council in the UK. And very clearly it has said, okay, you've suspected anaphylaxis, there's acute onset of illness and life-threatening airway or breathing. All you have to do is call for help as in any other situation of emergency. Adrenaline, 500 micrograms, that's 0.5 milligram, ml, sorry, IM, if not an anesthetist, or an IV if it's an anesthetist. Establishing an airway, a high flow oxygen, IV fluid challenge, and of course, then followed by hydrocortisone and chlorpheniramine. But the main thing is adrenaline. So a crash cart must be available there to manage anaphylaxis, and sending mast cell tryptase levels would make sense, because then retrospectively we can make sure that yes, this was a case of anaphylaxis. So very importantly, clinical governance plays a very important role, because poor documentation, if it's not documented, it's not done. And poor documentation most of the times is a cause for litigation and medical legal consequences. So everything, and that's why proformas. I talk a lot about clinical governance. So proformas for shoulder dystocia, proformas for PPH, proformas for maternal collapse and management, shoulder, whatever it may be. And that will give us a bird's eye view of what was done in a very simple manner, without missing anything, and with very little labor, manual labor involved. Getting our staff to be trained with ALS and BLS, as well as the advanced life support in obstetrics, and finally debriefing the lady and the family about what has happened. In conclusion, I'd like to say, yes, maternal collapse is really an unnerving clinical scenario. We must remember the A, B, C, D, E, F, G, and H, and also the A, B, C, D, E, F, G, H of resuscitation. Try to go through all our causes, because many a times it may be a diabetic on insulin, it just could be a hypoglycemia. And once you've corrected hypoglycemia, she's absolutely fine and sits up. And in cases of high spinal, there are various ways of, like, intubation itself can help in a huge way. So think of all the possible causes based on the scenario and treat it promptly. So in the UK, for example, we have these management of emergencies in obstetrics, where we were given different scenarios and we had to do the scenario. Somebody would record us, and then we would come out of the scenario and they would critique us. Okay, this went well, but this didn't go well. So that way, as a team management, we would have anesthetists, we would have obstetricians and nurses and the OT technicians. So as a team management, how best can we get the best outcomes for the scenario is very important. Not an individual training, but a team training. And special attention should be paid to the manual left uterine displacement, the difficult airway and an early intubation, and appropriate use of the PMCD to save the mother, and life-saving interventions such as defibrillation. All of us must go back and do at least one drill every 2 months in order to see how our defibrillator works. What are the medications to be given? The Code Blue team must be proactively prepared to respond to a maternal cardiac arrest. And also a maternal cardiac arrest committee must be formed at every institution. An emergency response plan specific to each institution must be developed and implemented. The committee would then link adult resuscitation teams with obstetrics, neonatology, etc. Because not all Code Blue teams are very well trained in looking after obstetric patients. It's a very different ballgame for them. And many of them get scared to look after pregnant ladies. So I think it's important for regular training, mock drills, and a review of cases should become routine for us in order to get the best clinical outcomes. And these are my references: the ILCOR guidelines and the European Resuscitation Council guidelines, and the ACG guidelines, and the maternal collapse and pregnancy puerperium, the GTG, the Green Top guideline from RCOG number 56. So these are all my references. I'm sorry I had to rush through, and there were so many other things that I wanted to tell, but I know that there was a big time constraint. Thank you for your patient hearing.
Thank you, Dr. Aruna, for that very comprehensive presentation. Of course, that is a huge thing, as you already mentioned. A lot of things are there, but whatever the main points you could convey, you have conveyed it. And I would like to thank the organizers, especially Dr. Rekha and Sneha, for giving us this opportunity to be the chairperson. Any questions from the audience? Otherwise, I have my own doubts, some doubts.
And Dr. Indukala madam also can contribute.
Yeah.
Indukala madam, please unmute yourself and you can opine on. Madam, unmute yourself.
Unmute.
Okay. Now, could you hear me?
Yes,
Yeah,
yes.
yeah.
So the one important thing I would like to say now is that along with the maternal collapse, the obstetrician attending the mother should not collapse. Okay, she should be calm and composed to start with, and of course call for the help. And as Aruna was talking about, if there is a blue coat team and things like that, it's beautiful. But otherwise, if there is no team and we are working in a hospital where such help is not available, then the things become very difficult. So in that situation, to manage the show, and especially in the present scenario with the the mentality of the patients and the public, so one should not get the disheartened and should be calm and composed to deal with the situation. That's what is my message.
I just want to mention one thing. You must have heard about this ECLS course. It is a compulsory thing for all the interns and postgraduate students. So that in a way will help them to do the initial necessary measures till they get the expert help. I think that will make them more, competent and confident to manage whenever a mother collapses.
Correct.
Yeah.
Yes. That's a
So
good initiative by the NMC to add that
it's
to
from
the
the
curriculum.
Rajiv Gandhi University and Jeev
Yes.
Raksha team.
Correct.
So most of the interns, most of the colleges are doing that. Okay.
Correct. I
So
know.
that way they are well, trained. But as Dr. Aruna mentioned, the feedback is more important. You give the scenario and give the feedback, like how you have done it properly or not. So that kind of a feedback also should be included so that they'll become more competent in such situations, emergency situations. Now, my question to Dr. Aruna is, see, you mentioned okay, suppose the patient collapses in the OT, you have all the personnel, okay?
Correct.
And even the perimortem cesarean can be done there itself, right? So suppose she collapses in the labor room, are we going to shift or do perimortem cesarean there itself? Because we have done it only for the purpose of separating the baby, not for resuscitation as such.
Yes, ma'am. That's true. No, I mean, that's very, very important. And all the guidelines very, very emphatically say that please go ahead with the PMCD, or if you want to call it resuscitative hysterotomy. It's called resuscitative because you're trying to resuscitate the mother
That's
in
true.
the place where it's done, where it's happened, because you're going to lose time, and
Yes.
every minute, every second counts for this mother who's getting more and more
Yes.
aspect. So I think mortality will definitely increase. So all we need is some betadine and a scalpel, because we're going to have a bloodless field.
Yes.
So many a times, if we get that extra cardiac output back into the heart, we may be able to do a better resuscitation, and just the BLS might work, and she might just,
Yes.
take a big gasp of breath and come back to life. So
Yeah, that would be great then.
Yeah, I know. Really.
Yeah.
There is no time to shift to either labor room or OT, and that is the golden time for us.
Yeah,
Golden
labor room is a perfect
Correct.
place to do PMCD. I mean,
Yeah.
people have done PMCDs in the even on the hospital corridors.
Oh,
So many a times. Yeah.
yeah. Yeah.
Even in the ambulances, I have
Yeah.
I can tell you.
I
Yeah.
see. Mhm.
Mm.
Dr. Sneha, your comments, please.
Role of
And
vasopressors.
Sheila Mane, ma'am.
Yeah, I was just listening to all these comments. So I think Dr. Indukala wants to say something. Madam?
Dr. Malini is asking
Yeah,
a question.
I just.
Okay,
Yeah.
yes, Malini. I heard somebody, so you can go ahead. No problem.
This role of vasopressors, when it should be given. Of course, if you are resuscitating the woman and still, if you have not done a cesarean, baby is still inside. So in such situation, definitely they say vasopressor should not be given. Maybe after,
So,
perimortem cesarean, maybe you can give.
Ma'am, vasopressors are used specifically in cases where there's hypotension, whether it is, so it could be hypovolemic shock or it could be septic shock. Yeah, so in such situations where there is, hypotension because of a shock and because of hypovolemia sepsis, that's when we use vasopressors or inotropes in order to bring up the blood pressure. Many a times we use this in critically ill women rather than in a maternal collapse scenario.
Okay, fine. Right.
So I think what I would say as the concluding remark, that it's not the obstetric unit, HDU or ICU, it's the obstetric team that matters.
Yes.
The
It's a
eye
team
see
work.
what the mind knows. We are supposed to know each and every step as far as the resuscitation is concerned. And of course, whenever the patient collapses in front of you, you have to call for shout for help, but you can't wait for the help. So you have to keep on doing something or the other. You can't refer this patient or you can transfer this patient in this situation. In fact, the patient will worsen. So every team member from the obstetric unit must be well versed with resuscitation part of this. And that is why maternal collapse is, as we say, it's very, very unpredictable. Obstetrics per se is so unpredictable. So we have to be well versed with the resuscitation parts. And as you rightly mentioned, that you don't have to see where the patient is, maybe even in the corridor or in the ambulance. You should go ahead with the perimortem cesarean section, which not only saves the baby, but also may save the mother as well, because it helps you in the further resuscitation. So,
in my experience, madam, I'm Dr. Shailaja. So I work in Rainbow. So my experience, I had maternal collapse at home. So in an apartment. So where we had to rush, even before ambulance arrived, I had to do the cesarean at home on her bed.
My God. Wow, Shailaja, I didn't know about this. Right. You must tell us about that. Yeah, wow. Later. Okay.
So
what did you use? You used the kitchen knife or
What was the outcome?
Kitchen knife. Yeah,
oh,
kitchen knife.
Did she survive? Did she survive?
No, she did not survive. Baby survived actually. So baby was shifted to NICU. So by the time she was shifted to hospital, she had collapsed.
Oh, gosh. Wow.
That's nice.
Yeah. So,
but ma'am, I think the most important thing is, again, as I think Dr. Sneha, you could take this forward, just as how important documentation is, all the proformas and protocols, and just having these algorithms pasted on our walls. Anaphylaxis का जो algorithm है, इतना beautiful है, एक ही glance में सब कुछ पता चल जाता है, and then that should be hanging from every anesthetic machine and even labor ward, because whoever is looking at it, उनको बिल्कुल पता चल जाता है कि क्या देना है तुरंत. Because otherwise, for example, everybody talks about chlorpheniramine as the first step for anaphylaxis. It's not chlorpheniramine. It's not CPM. देना तो epinephrine है पहले, adrenaline. उसके बाद hydrocort, उसके बाद chlorpheniramine. So I think these protocols, and as Foxy, I think.
Yeah, our request to share those algorithms with us. It will be of great help, and we can maybe we can share with all the members. Maybe we can prepare the hard copies for that.
Yes.
So
Arun, I just wanted to ask you whether this mast cell tryptase, is it available? That test is available?
Yes, madam. It takes a while to come, though. It takes at least 48 hours, is what I heard. But sometimes it can be fast tracked. But that is it is a hard,
that's maybe for medical
hardcore diagnosis of anaphylaxis.
Anaphylaxis. No, why I'm asking, because this amniotic fluid embolism is supposed to be a anaphylactic reaction for the amniotic fluid. That's what is the recent view. So maybe we can prove that it was amniotic fluid embolism, because because the presence of this vernix or lanugo and all will not prove, because it may be present in other normal pregnant women also. Okay. So maybe for medical legal purpose, or we can prove that it is amniotic fluid embolism. Because many a time the obstetricians will be blamed, suddenly patient was quite all right, a healthy woman, suddenly collapses and she dies. That is the worst this thing. nightmare for both obstetrician as well as for the
Absolutely.
patients also.
Yeah. No, I think it's
Yeah.
worthwhile sending mast cell tryptase in such scenarios.
Yes.
Yes, ma'am.
Thank you. Thank you so much for all these inputs. Thank
Thank
you,
you.
Dr.
Thank you,
Sneha,
Dr.
again. And
Thank you.
Okay.
Thank you, Aruna ma'am, for your fantastic presentation and
Thank you,
great
Madan sir.
inputs from chairpersons. Thank you, Malini ma'am, Indukala ma'am, and Rekha ma'am for this
Yeah.
wonderful
Thank you,
Thank
Dr.
you.
presentation.
Madan, and thank you, Aruna.
Madan.
Thanks, both of you.
Thank you.
Thank you,
Thank you,
my
Sneha.
co-chairpersons, for your valuable inputs. Thank you,
Yeah,
Indukala
thank you,
madam and
thank you.
Malini madam. Thanks for
Thank you. Thank you.
accepting our
Thank you.
invitation and attending and giving us great inputs.
It's a
Thank you.
pleasure. And that too,
Pleasure.
the Aruna is our student. It's a
Yeah.
pleasure.
Very
And-
enterprising and a smart student, and we
Yes.
really feel proud
Very
of
happy.
you.
Yes.
Thank
May I
you.
invite
Thank you
Dr.
so much.
Monica? Dr. Monica for
Yes, thank you.
further.
Thank you, Dr. Madan. We now move forward after an excellent presentation by Dr. Aruna Muralidhar ma'am. She's already laid the bars for the panel discussion in labor ward emergencies. I hope the panelists have taken all the messages from her to be answerable in the panel. To moderate this session, we have none other than Dr. Sneha Bhuiar madam. She will be talking about labor room emergencies. Madam has been already introduced earlier. So we move forward with the introduction of our panelists. Dr. Srimati Raman Madam, she's a consultant at Bangalore Memorial Hospital, Bangalore. She's also the Joint Secretary of the Bangalore OBGYN Society, the AICC South Zone IRC Co-opted Fellow Representative. She's the MRCOG examiner, the reviewer for the Green Journal ACOG. She's ranked in the 10% reviewers from 2018 to 22. She's also a DNB trainer and trainer in our GUHS fellowship program. She has more than 10 gold medals and 13 prizes to her credit. We welcome you, ma'am. Our next chairperson is Dr. Shailaja, madam. She holds a fellowship in cosmetic gynecology. She is a consultant at Rainbow Children's Hospital, BG Road, Bangalore. She's a gold medalist in DGU and MS OBGY. She also has received the BJ Gowda and Leelavati Young Talent Award. She has many publications to her credit. We welcome you, ma'am. Our next panelist is Dr. Nalini Arun Kumar madam. She's a senior consultant at Bangalore Baptist Hospital. She's an undergraduate and postgraduate teacher and examiner. She's also a part of the National Committee of the Spina Bifida Foundation. We welcome you, ma'am. Dr. Sashikala Karant is the professor and head at St. John's Medical College Hospital, Bangalore. She is a member of the organizing committee of AICOG 2019. She has been a faculty at both state and national conferences. She's an executive member of the Bangalore Society for more than last 5 years. She's received a certificate of appreciation for contribution in preparing the competencies for postgraduate courses in OBGY. She's also received the C.S. John Prize for the best paper. We welcome you, ma'am. Dr. Satyavati ma'am holds a fellowship in maternal fetal medicine. She's a senior consultant at the Bangalore Baptist Hospital. She's also a DNB trainer and examiner. She's also an FNB trainer and examiner. We welcome you, ma'am. Dr. Rajni Uday madam is a professor and head of the department of the Saptagiri Institute of Medical Sciences. She is highly experienced with more than 30 years of service at the MS Ramaya Medical College. She is a distinguished academician, teacher, and surgeon, serving as a professor at present. We welcome you, ma'am. Dr. K. Srinivas sir is a professor at Bangalore Medical College in RI, Bangalore. He has also been a gold medalist at MBBS in DNB. He's edited a book for postgraduate ward rounds, contributed to many chapters, and has 17 papers to his credit. We welcome you, sir. I request Dr. Sneha Bhuiar madam to now start with the panel discussion.
Yes. Thank you so much, Monica, for that wonderful introduction. And I welcome all the esteemed panelists. As we know, our panelists are very well experienced as well as, they're updated. So we're going to have lots and lots of inputs from your side. We have Dr. Shailaja, Dr. Srimati, Dr. Nalini, Dr. Josna, Dr. Shashikala, Dr. Satyavati, Dr. Rajani, and Dr. Srinivas. So, friends.
Dr. Josna is not there.
Acha, she's not there.
Yeah,
Okay.
yeah, she has sent the apology and others are all there.
Okay, so no worries. So friends, childbirth is a sentinel event in the lives of woman and her family. I'm sure all of you have experienced this as well. And that's the very reason, people say that it's a second birth of that woman. So birth is not only intensely emotional, but it is intensely physical as well. And this is just seen in the movies 1, 2, 3, and the baby's out and things are happy. So our aim as obstetrician is to have the healthy baby from healthy mother. And of course, for the mother, it should be a emotionally fulfilling experience. I'm sure maybe at least 3.5 decades ago when I was a trainee resident, and now even after 32 years, another 3 decades of experience, the dilemma regarding the second stage especially remains the same. And of course, the action is taken as per whether you belong to the protagonist of active management of labor, where you go for the timely and appropriate intervention, or you are the follower of masterly inactivity and watchful expectancy. So friends, let us go ahead with this case scenario straight away. So we have Dr. Shailaja, this is the first case for you. We have taken very simple practical cases which you tackle in day-to-day practice. So primary gravida, 37 weeks, she comes to you in early labor. When you examine, you find the vitals are normal. She's having mild contractions, 25 seconds every 4 minutes, mild to moderate contractions. Head is floating, fetal heart is good, 140 per minute. There is a sudden drop in fetal heart rate. What is your diagnosis and how will you confirm and what will be the management? Dr.
So
Shailaja.
good evening, everyone. Yeah, good evening, everyone. See, this is primary gravida. So she has got a floating head and there is sudden drop in FHR in early labor. The most probable diagnosis is cord prolapse only because her vitals are stable. She's not having any such acute pain, so it is cord prolapse. So we need to confirm the diagnosis by doing speculum examination or digital examination. So once the diagnosis is confirmed, because vaginal delivery is not imminent here, so we need to consider category 1 cesarean. That is, we have to deliver her within 30 minutes.
Yes,
So
Dr.
first step is
Shailaja. Yeah, Dr.
Okay.
Shailaja, I'm sorry, I would like to interrupt you here. When you do the internal examination, speculum examination, you find that a fresh gush of amniotic fluid is coming, but you don't see the cord there, prolapse anywhere in
So
the.
we need to examine her for cord presentation. Is it being compressed by the
she's
presenting
membranes
part?
are already ruptured, right? So you have
Yeah.
to, when you do the internal
So
examination,
that's what, by the side of the presenting part, if at all any cord is there, so which is occult cord prolapse.
Right.
So it can be found out by the side of the head, which has been compressed by the
Correct.
presenting part.
So that is what we wanted to stress. So it can be
Yeah.
occult cord prolapse, it can be the frank cord prolapse, right? So
Yes.
how will you manage this patient?
See, the first and foremost thing after confirming the diagnosis here, because vaginal delivery is not imminent, we have to consider cesarean section only. It should be category 1 cesarean section. That is within 30 minutes, we have to take out the baby because FHR is dropping. So we have to call for help. Senior obstetrician should be there, anesthesiologist should be there, and neonatologist should be there. So here, two things we have to concentrate. One is to decrease the cord compression. How to do it? We have to elevate the presenting part either manually or filling the bladder with the filling the bladder. So we have to put her in the knee chest position or left lateral position. So head down with pillow under the left hip. So this is regarding cord compression. So next point is vasospasm. If the cord is exposed, so it has come out of the vagina, we have to handle the cord very, very minimally. Otherwise, it will go into spasm and cause further fetal distress. So one more thing, we should not try to replace the cord above the presenting part. That is to be kept in mind. Otherwise, we will be a little heroic to do that and continue the labor. That should not be done. See, even after elevating the presenting part, if the FHR is not settling, what to do next? So we have to give her tocolysis. So that will help to buy some more time for us to do the cesarean. So then we have to discuss with the anesthesiologist regarding the mode of anesthesia.
I would like to interrupt you here, Dr. Shailaja, and I would like to go ahead with Dr. Nalini. You have, the message from this discussion is we have to deliver the baby at the earliest because the baby is live and is in distress, right? If the baby
Yes,
is dead, then of course you have ample time to go for augmentation and deliver her vaginally. Now that this baby is in distress, you have to deliver the baby at the earliest by whatever modality at the earliest, because suppose she's nearly full dilatation and she's pushing. So even if you have made, I mean, by the time you should make all the arrangement for cesarean section, but maybe she can deliver in OT. So that is how you have to just, augment or hasten the delivery by whatever modality, may it be an instrumental delivery as well. So, but as you are saying, if at all she is having very strong uterine contractions, but if that is not progressing, then only there can be a role of tocolytics, maybe even the general anesthesia. Any role for Dr. Nalini? Can we have your opinion about tocolytics and amnio infusion? Do we have Dr. Nalini here? No? Okay. Anybody else?
We normally use Dr. Srimati here. We normally use terbutaline, though they say nitroglycerin and other things can be used. We usually have terbutaline in our labor rooms, so which is very easy to use. And we normally have given, even if she doesn't have any contractions, we have given tocolytics because even one minimal contraction can compromise the fetus because the pH drops almost 0.01 per minute. So we have given terbutaline 250 micrograms subcutaneously, and it acts immediately. We don't have to be worried about PPH because it's only short acting. So we definitely would consider tocolytics, even if she does not have many contractions. Amnio infusion, I don't think there is any role. In fact, amnio infusion can precipitate further cord, so from coming down because you're pushing, fluid inside, and this can hasten more cord from coming down. So definitely no amnio infusion. Maybe needles, and of course, as she said, filling the bladder, considering tocolysis and shifting her to theatre for category 1 cesarean section if vaginal delivery is not feasible.
Right.
Good evening, madam. Good
Yes,
evening.
please.
Good evening. I'm Dr. Rajni here.
Yeah, please.
Ma'am, we don't have any time to think only. If the head is high up, cord prolapse is there, better to just the hand which is kept in the vagina. The person who has done the PV examination, he should not remove his hand. Or we should raise up the, flex the legs and see that the mother is, that area is lifted up and wheel to OT and do as early as possible the cesarean section. And my experience with the terbutaline was 20 years back. Now I have not seen it is available, and I have not given for cord prolapse.
Available, madam.
Cord prolapse I have
available.
not given. And when the head is low, apply forceps or vacuum and deliver.
Yes.
Head
So
is
only if she's fully dilated.
Fully
If she's
dilated, head is low.
vaginal delivery is imminent, then we can do that.
Yeah,
But
head
here
is
it
low.
is early labor.
Head is low, head is seen. Apply forceps or vacuum and immediately you can deliver.
Yes. So all of you have discussed the same point in different fractions, that yes, because the baby is live and is in distress, or baby is live, you have to deliver the baby at the earliest by whatever modalities. As we said, if the delivery is imminent, you just try and hasten the delivery, maybe by instrumental delivery, instrumentation or vacuum, whatever you are comfortable with. If it is not imminent, then of course the moment, first and foremost, I said that even if you feel that she's going to deliver vaginally, still you arrange for all the operative procedure, because anytime you land up into problem, you can go ahead with cesarean section at the earliest. Meanwhile, when you are, by the time the things are getting ready, then of course left lateral or niches position, oxygenation, all these things. But I don't think we, delay further by giving the tocolytics or amnio infusion. I think that should be the very clear-cut message from this. So at the earliest, we have to deliver this baby. Now, suppose what are the now why this mishap happened? Because previously it was not diagnosed. So what are the RCOG guidelines about this?
See, cord prolapse, can I go ahead, madam?
Yeah, sure.
So antenatal screening ultrasound.
The question. I would just twist the question. See, what are the
got it.
Antenatal
surveillance.
Yes.
So antenatal surveillance, whether cord presentation is there, So below the presenting part, we can screen it, but it is not very sensitive and specific method of doing it. So, but it is done only in abnormal presentations, like breech presentation, we can think of doing this screening test. So otherwise, see, we have to take precautionary measures when we are doing ARM for the mobile head. So we should be cautious. And whenever we do the vaginal examination, we should see whether any cord presentation is there. So before doing the ARM. So if at all it is PPROM, so breech presentation, immediately after rupture of membrane, we are supposed to do the speculum examination or digital examination to identify it. And also we should hear the FHS for 1 minute following spontaneous rupture of the membrane. So we need not suspect cord prolapse only when the head is well engaged and spontaneous rupture of the membrane. When the heartbeat is good, we need not worry. Otherwise, we have to be very, very cautious about cord prolapse.
You have to hear the fetal heart for 1 minute, you said it right. But whenever you have spontaneous rupture of membrane, one must go for internal examination, confirm and rule out the cord prolapse or cord compression. So
Yes,
this is what I was talking about. There are certain situations where you have either preterm labor or preterm PROM, polyhydramnios, multifetal gestation, transverse lie, oblique lie, breech, and other malpresentation where you don't have the well-fitting head. So these are the situations where they are more likely to go into this cord prolapse. And then, of course, you have to identify such patients at the earliest, and then you try and avoid the artificial rupture of membranes. Even the manual rotation of fetal head, sometimes the cord can come by the side. And of course, absolutely no to the ARM, as we have already said. But whenever you have the spontaneous rupture of membranes, do hear the fetal heart sounds for 1 complete minute and go for internal examination, as has been discussed already. So what I was talking about is what are the RCOG guidelines for, if at all you want to avoid this situation. Sometimes you can have what is called as cord presentation. So can somebody discuss this point?
So basically, there is lots of confusion about the definitions, ma'am. So various, sort of terminologies are being used, but the accepted terminology is cord presentation is when you have intact membranes and the cord is coming below the presenting part. So I think if we identify it, then it's important.
I don't think we should have any confusion, right?
Yes, ma'am. But there are quite a few terminologies which are floating around. But I think it's very clear cord presentation is when the membranes are intact and the cord is below the presenting part, and prolapse is when the membranes are ruptured.
Yes.
Right.
If you identify, you avoid doing an ARM and avoid having a prolapse in your hand. So obviously, the easiest way might have to be doing an emergency cesarean section alone, because gone are the days when we have gone and repositioned the cord and, carrying on for a vaginal delivery. So, but only thing is we want to avoid having a cord prolapse in our hand, because that is going to be creating vasospasm and hypoxia for the baby.
Yeah. So whenever you have a suspicion or diagnosis, even with ultrasound, that there is a phonic presentation or cord presentation, this is a lady who is to be hospitalized at the earliest. Near term, whenever you have diagnosed that there is a phonic presentation, then she is not for spontaneous labor and delivery. You have to post her for elective cesarean section. That is what is the recommendation by.
Even in PPROM with malpresentation or a malpresentation, especially a transverse lie at term, we might have to admit them, because obviously the risk of ruptured membranes and the cord coming down is higher.
Yes. So the moment you diagnose, you have to hospitalize and decide for elective cesarean section in all these conditions, as we have already discussed about it, right? So RCOG says that you have to identify the patients at risk. You have to avoid the aggravating factors like doing ARM. So a strict no to ARM. And of course, if at all she lands up into spontaneous rupture, then you have to do the internal examination, rule out cord prolapse, and of course continue for the fetal monitoring as well. So these are the predisposing factors and aggravating factors we have talked about. First and foremost, yes, anybody wants to add anything here?
Madam, before going for the second case, what I want to emphasize in cord prolapse is the clinical governance point. So we have to send paired cord blood sample for pH and base excess. That is the first and foremost thing. So second is documentation. There should be pre-formatted sheets to record all the clinical events. And also we have to debrief the mother as well as like we have to raise the incident report and promote the training of the staff.
Yes, perfect. So
having a cord prolapse set, ma'am, that's what we have in our unit. We have a cord prolapse kit where we have the Foley with that bladder syringe and everything, because that makes it much easier for us. Though manual elevation is best, but sometimes, we might have to, it might be a bit difficult for us pushing her through the tricky, corridors with our hand inside the pelvis. So we tend to have a cord prolapse kit, which is sort of very easy for us to use to fill the bladder.
yes.
So do you think that it has to be incident report has to be done for this type of patient?
Yes, ma'am. Cord prolapse is an incident.
Actually, we are not doing it actually. We are not doing it actually.
It is an incident, ma'am, because obviously 50% of the times cord prolapse they say is because of an iatrogenic intervention.
Okay. Okay.
Yes. So basically, even when it is a panic situation, you and your team managing the patient. Can you hear me?
Yes, ma'am.
Yeah, can.
So you and your team is managing the patient and to its best, but you should have somebody who will communicate with the relatives. You should have somebody to go for the informed consent. So communication should go on, and at the same time, the documentation. So communication and documentation should go simultaneously along with your management. Otherwise, we obstetricians are trying our best to manage the patient, and there is a lacune in the documentation. Okay, so let us move ahead. We have lots of interesting cases here. So here you have 28-year-old, fourth gravida. She has had previous 3 spontaneous abortions. Now she has reached 39 weeks in labor, and now she delivers a full-term baby girl. Placenta is not expelled even after 45 minutes of birth. So Dr. Josna is there, not there, I think. So anybody can take up this case. What is your diagnosis? When do you call? What is your diagnosis?
It is a retained placenta, but when do we call it as a retained placenta? I would probably need to know a few more information, because whether she has had a physiological third stage or active third stage, though we don't actually propagate a lot of times physiological third stage, but midwifery units, they may do. So I think that would help me understand this time frame, because if it's active management, then 30 minutes, I would say it's retained. Whereas if it's physiological, then I could even wait for another 15 minutes if she's not bleeding.
Yeah, but now that she has crossed 45 minutes. So even both the cases is a case of retained placenta, right? So
the bleeding, we had to intervene, madam.
Anytime bleeding, wait.
Then we can wait.
Yeah. So now that patient has come to you, you will decide what to do, how to go ahead.
So obviously look for any evidence of hemodynamic instability, whether she is bleeding, and obviously catheterize the bladder, see whether she has had an uterotonic. If not, consider giving another uterotonic, and then do a vaginal examination, see if the placenta is separated and retained, or whether it is not separated. So I think that becomes, and of course looking at the tone of the uterus, because that will help me plan the next step. Because if she's actively bleeding, then obviously the management would be different, but she's not actively bleeding, then I have a bit of a time to, sort of plan my next interventions.
Yeah. So your patient is hemodynamically stable. She's not bleeding actively, and uterus is, you feel that, it's globular, quite well contracted. Okay. So now how will you go ahead?
So I would just examine in the labor room to see what is happening, because if the cervix is completely closed and there is no signs of any placental separation, then I would probably make a diagnosis. It's a non-separated placenta. So obviously, which means that I will have to give her some form of an analgesia and anesthesia. So I might be inclined to take her to theater, give her some kind of anesthesia. It could be
I want to interrupt you here. You will take her to straightway to operation theatre, or you will go for ultrasound and rule out the morbidly adherent placenta?
Ma'am, if there are no other risk factors, I may not always.
I don't think, even nowadays you are facing so many, even if without scar, even without any scar, even a simple D&C, this lady has had
3 miscarriages.
abortions, so maybe evacuation curettage sometime earlier. 3 abortions she has had. She is a case of a high risk.
We have not routinely done a scan, ma'am. So we have done a removal and a scan guidance, but not for confirming whether it is not. So what we have done in our usual practice.
We never do scan before. Maybe under scan guidance we may do it, but
already more than 45 minutes and she is not bleeding. See, if the placenta gets separated from some of the other side, then she starts bleeding. If she doesn't bleed, that means it is not getting separated from anywhere.
Maybe
Okay,
the
so how will you
placenta,
go ahead? How will you go ahead?
accreta, increta. If it is
Okay,
there,
you try
we need
and
to diagnose.
go in the theater, try to remove it. There is absolutely no plane of cleavage. Now what will you do?
So then obviously now was a
Then we can do
diagnosis
the
of
western
So
endeavor.
you will keep the ultrasound in the operation theater.
So then
Okay,
we can
so
look
it's
for
one and the same.
lacunae.
Basically, if you have the ultrasound available, might as well put the probe there. I think it's not like this. You go around. Better to be, on the safer side, because if you pull, it will. You may land up into uterine inversion also if it is not separating, right?
But
So,
posterior placenta, it is difficult to diagnose in case even if you
yeah,
do
but
the
why to
ultrasound
think of the
also.
negative aspect only? If at all we are having the positive aspect,
that I okay.
keeping the probe is telling you that yes, it is adherent. Don't touch it. Okay.
Madam, as you said, patient is not bleeding, stable.
Yeah.
We'll go ahead with the ultrasound.
That is what I'm saying. That is what I'm trying to say. Otherwise, you people are right. If she is bleeding, you have no option but to go for prepare fast for MRP, right? But then if she is not bleeding and you feel that, it's most probably a non-separable placenta, just put in a probe and see that, yes, if it is showing that it is adherent, go ahead. It gives you a guide. If it is not adherent, then also you're sure that whenever you do the MRP, it will come out. Right? So how
Actually,
do you do it?
for time being, we are doing what Dr. Srimati Raman, she told, we are doing the same thing because we wait up to half an hour. Even though if the patient is not bleeding, we'll take the patient under general anesthesia because of the relaxation. We'll try to do the separate the placenta. If it's under ultrasound guidance, then if it is separate, it's fine. Then we'll start with syntocinon and then take it out.
But this is nice point to learn.
Now I
When
think we
somebody
can
is not
change it
bleeding
also.
with
Yeah, we can change it also.
Stable patient,
that's
better
what.
to do ultrasound. Stable.
Yeah, we can
Stable
change
patient
it.
is
Especially when
not
somebody is
bleeding,
not
better to do
bleeding with
ultrasound
placenta
and
inside.
rule out that it is not morbidly adherent or placenta accreta spectrum, because then you are sure. Then you will catheterize her, you will give her lots of oxytocin, whatever you want to give, and then you are sure that whenever you do MRP, she is going to be, the placenta will come out, and then you will be able to manage the PPH if at all it happens. You can give her prophylaxis as well. But when you are seeing that, it is morbidly adherent, there is no plane of cleavage, then you should not, take her for removal in the
OT or removal.
right. So that is.
I think here, madam, we have to think of two things. One is the risk factor which we are able to identify in this case. The second is a case in which no risk factors are there. So with Dr. Srimati's opinion, I agree if there are no risk factors, but with 3 abortions, probably she would have had a couple of curatages or whatever it is to remove the products. So I am really scary to take her to the OT and blindly put my hand and remove the placenta. I would like to confirm that it is not a PAS.
Right. Perfect. So good. We are waiting for you to speak about this. And definitely these are the, predisposing factors. As all of you know, any scar on the uterus, may it be myomectomy, seizure, may it be just a simple curettage as well. Septate uterus, you can have septal resection, myomectomy, and even the lateral metroplasty. So all these things can. So as we have already talked about, do we empty the bladder, give uterotonics, and maybe, because if she has a plane of cleavage, it will just separate on its own. Maybe you have to go for MRP. So somebody to describe the MRP. I think anybody can. Dr. Nalini, do we have? Yeah. Anybody can take up for MRP in short, and then we go ahead.
Yeah, the precautions where we, with the left hand on the lower part of the, or the abdomen, lower part of the pelvis, with the right hand, go along the cord to the where the placenta is attached. See the lower edge of the placenta, like as you separate the leaves of the book, like that.
Movement.
You should get into that, and along that cleavage only you should go and try to separate the placenta along the cord.
And left hand can give cord traction.
Yeah.
I think anesthesia, having a good anesthesia becomes
under anesthesia only it is done.
Uterotonics and
Having IV antibiotics on board, I think those are important prerequisite because obviously we are going to, sort of risk infection. So I think that becomes very important, and be careful about PPH because she might, once the placenta comes out, she might bleed. So I think we need to be careful about PPH.
Right. Suppose now you have removed the placenta, you have given adequate uterotonics. In spite of that, there is profuse bleeding. You have given uterotonics. How will you manage this patient?
In our unit, we use suction, ma'am. We use a suction cannula because we have seen it make a big difference. Obviously, one thing is we need to make sure that the placenta is complete.
Complete placenta has come out. That's my.
So having a scan and checking the placenta becomes important before going ahead with any other management steps, because there is a good chance we have left behind a cordylant of the placenta, which might be a common cause of PPH.
So
bimanual compression also will do better, madam. Bimanual compression after ensuring.
So first and foremost, when you remove the placenta, examine it. That is what actually I wanted to say. You examine that it is completely separated and expelled out. And then, of course, the role of bimanual compression, if not the balloon tamponade and suction.
Bakri balloon.
Yeah.
And I think one care during MROP that once your hand is in, come out with the placenta. Don't keep on removing and removing the cotyledons piece by piece. That should never be done. As far as possible, remove the placenta as a whole, because this problem of retained cotyledons and things can occur if you keep on removing it piecemeal. So that care has to be taken. And rarely I have seen 2-3 cases of rupture uterus, iatrogenic rupture with MROP. When the patient has a relaxed uterus and with anesthesia, over enthusiastic attempt to remove the placenta can sometimes cause damage to the myometrium and sometimes perforation. We have lost one patient about 15 years back with an MROP.
Okay.
So and suction cannula also, madam, when you use with a removal after removal and when the uterus is relaxed and you are using this cannula for contracting the uterus, it can perforate the uterus. One of our patients, she came, we could not make out the diagnosis at all. After interiliac artery ligation, embolization also, patient did not recover. Then later we came to know, when we opened up, we found out there is a perforation in the posterior aspect of the uterus. So suction cannula for PPH control, you should be utilized with the use with the precision.
No, one point
that is why the gentle removal of placenta, and of course we said the Bakri balloon or balloon tamponade. Yes, madam.
I just want to add one point here. See, suppose the retained placenta is because of the atony of the uterus and you're doing manual removal of the placenta, we always tell, everybody, we give the instruction that like you have to remove the placenta, don't remove your hand from the uterus.
Yes.
Give the uterotonics, make sure that the uterus is well contracted and slowly remove the hand.
Uterus should hug on to the hand.
Yeah. Yes. So in case like if there is atony, you can even give bimanual compression at that time.
Yes, yes. And that's the very reason we are stressing on the uterotonics. When you are doing the MRP, we are always stressing that, the bladder should be empty and the adequate
uterotonic should be given.
Yes. So that is all about MRP and the retained placenta. We will not discuss because nowadays we have heard lots about placenta accreta spectrum. In that also, I'm sure you all also have changed your views. I think maybe around 5 to 7 years back when I was moderating the panel discussion on PAS, I used to say it has to be a elective obstetric hysterectomy. But, now the concepts are changing because you do have conservative uterine surgical procedures, including triple P procedure and even the other ones like what we call it as AMOGS stage and the piecemeal separation of placenta followed by the compression switches or maybe even the myometrial patch resection followed by balloon tamponade. So nowadays you have the options. People are doing it very routinely. The people have achieved the expertise in going ahead with the conservative surgical management for PAS. Otherwise, previously we used to say that it should be elective obstetric hysterectomy if at all the patient has, morbidly adherent placenta. So we go
But
ahead.
we are using that this thing actually. Intervention radiologists are there in our hospital. What
Yes.
we do is we'll deliver the baby. They'll put a stent and for uterine artery embolization. Then afterwards we'll do the cesarean sections. Then they'll do the embolize the umbilical uterine artery. Then we'll decide whether to remove the this thing placenta or not. Okay, even the one placenta recently we have done is that placenta percreta also we could save the uterus, because that our IR consultant is very good and he could the embolize each feeding vessels and all. It percreta also we could save
Exactly.
the uterus.
Exactly.
So
That is
that's the
what.
one
That is what
advantage.
even the triple P procedure says, that you go stepwise devascularization and then you go ahead with the mapping of the placenta and of course the patchy resection. So similarly, interventional radiology definitely has a place in PAS. So we go ahead with the third case now. We have this second gravida para one who has delivered normally vaginally previously. Now she has 36 weeks pregnancy and comes to you with strong labor pains. Her vitals are normal. Fetal heart is very good, 140 per minute. Cervix is fully dilated, fully effaced. Breech presentation. Station +1. So it has come as a gift to you. Pelvis is adequate. How do you manage this patient? How did
Madam,
Dr. Shashikala?
Here there is no time for a cesarean sections. In case if I have a cesarean section in the labor room, we can explain the complications of the breech delivery, and we can, if the patient is willing, anesthetics are available, we can do quick cesarean section. Otherwise, we have to do the assisted breech delivery. The spontaneous, there are 3 types of breech delivery. We can't do other 2, but only that assisted breech delivery we can assess, because pelvis is adequate and previous patient has a previous normal delivery, vaginal delivery, and around 36 weeks. Other things I don't know, other contraindications like whether patient had that oligohydramnias or any patient had a GDM and all those things I don't know. But in this scenario, we can do the assisted breech delivery after counseling with the patients. We have to explain the patients regarding, because she has come in a large stage, so we have to explain about the neonatological problems because of the breech extraction and morbidity and mortality. We have to inform to the anesthetist, inform to the neonatologist also, and
so
we
informed
have to,
written consent about the pregnancy outcome.
informed and written consent we have to take, and then we have to start the IV line, arrange the blood, and then we have to ask her to, we have to wait for the vaginal delivery till the assisted breech delivery we have to do, but till the delivery of the
till the time you explain everything, take everything in writing and prepare for Caesar, she may, just deliver spontaneous vaginal.
But in emergency,
that is also there. That is also
in
there.
emergency, should we really take written consent?
It has to be.
Is it mandatory?
We have always been talking about this.
Because she is a second gravida station at 0, almost +1 station. She may deliver quickly. So that time, whenever we were doing it, by the time we going for a cesarean section, she may deliver. So that's why we have to take a written.
Yes, but then ideally, we have to think for an ideal situation. We have to go ideally that by the time you see what Dr. Shailaja is talking about, taking a consent, you ask your assistant to write it down for you. You dictate.
That's also can
you
be
don't
done.
leave the patient, so that you are doing your duty properly. But documentation. We are coming back to the same thing. We are communicating, but if we are not documenting, good documentation is good defense, and no documentation is no defense. Okay, so whatever good you do to the patient, you have to document.
The only thing in emergency is verbal consent is more than enough compared to written consent. So
provided nothing goes wrong. Provided nothing goes wrong. Dr. Malini.
No, after coming head, we can never predict, what's going to happen to the after coming shoulders or even after coming head. So you might lose the baby, So you have to explain to the attendants
second gravida
also.
fully dilated, station 1, we don't know, Shailaja, by the time we start, by the time give anesthesia, she may deliver. So in case head get trapped and all. So in that way, by the time this preparation done, better to take a consent. Once one of them, they will explain and written consent we can take. And simultaneously we can prepare for a cesarean section at the same time if we have to be ready for even to conduct a assisted breech delivery. delivery also. And
Let
also in
your
case
OT
if
get ready. Let your team work for you. But you have
Yes,
to make
yes.
sure that you are explaining everything to the patient, and it is a shared decision. In fact, you can put the onus to the patient, saying that you have just arrived in this situation, and this is what we
which
can
is the
do.
best we are doing it. Yeah, which is the best for you that we are doing it.
Yes.
That's the one
Okay.
thing. And one more thing I want to ask is that in case if there is any footling presentation and all, even the younger student consultant, they should not fiddling with the breech or this thing, foot and all, because whatever it is, if it is delivered, we have to wait for the deliver on its own till the delivery of the umbilicus. Then we have to do the breech extraction.
Okay.
Assisted breech delivery.
So your baby is by the time delivered up to umbilicus. How do you do the assisted breech delivery now?
That once the breech, this thing is once the umbilicus is visible, push this thing umbilicus is towards the one side so that it will have to avoid the compression, and then breech towel it should be there. We cover the baby with the breech towel till the these things. We have to hold the baby with cover the baby up to the femur, only in the legs, and then we have to hold the baby with the femoropelvic grip, and then we have to gently see the deliver means like we have to wait till the delivery of the scapula, lower end of the scapula. We see that actually there is a winging of the scapula is there or not, or if the parallel, that shows that it is a flexed arms. If it is a winging of the scapula is there, means like where it has the extended arms. Then the extended arms means like it required a Lausset's maneuver to deliver the hands. Then once the hands are delivered, then we hang the baby on its own weight, and then once the nape of the neck is visible, then we have to do the Burns-Marshall technique or a delivery of the by Marshall-Smith-Wiley technique, or we can apply the Piper's forceps. The principle in this thing is just no pulling or no pushing, no fundal pressure. Okay, whenever baby is delivering, that time only the suprapubic pressure when the baby is delivering, head is delivering.
One more thing,
always keep the back anterior.
Keep the back anterior. Keep the back
Always keep the back. Don't allow it to go posterior. Okay.
Also
So
have
that
a timer, ma'am.
the head doesn't deflex. Yes.
Also have a timer because we want to know how long it's taking, because that is also an important factor because it increases the risk of hypoxia.
Yeah, that also at the same time you have to see the tone of the baby and color of the baby. In case if the tone of the baby is low or the color of the baby is turning to the blue, then immediately expedite the delivery. Or if there is any that all fours, sometimes they say that it may help. That all
Role of episiotomy, Dr. Shashikala?
Yeah, role episiotomy is required because they say that controversial or not, but it's a good actually because it easy facilitator
For breech, it is not controversial. I think any manipulative or instrumental vaginal delivery, you must give a liberal episiotomy. May whatever the controversy say, because it's always good to have a clean cut episiotomy rather than having multiple cuts here and there and maybe extension to the anus. So rather than landing
here
up
they say that episiotomy
between Mauritius Belly and Burn-Marshall,
it easy facilitate the delivery of the soft tissues. Because she's fully dilated, we are not worried about the entrapment or anything. But because they say that it is easy facilitate the easy delivery of the soft parts if you give episiotomy.
Between Mauritius Belly and Burn-Marshall, which is
Marcellomy weight technique is better. That is better.
Yeah. So anybody does Burns-Marshall technique? Some people do Burns-Marshall routinely like this, turn the baby. So you catch hold of the ankle and with the long circle you put the baby on the abdomen, mother's abdomen.
Because it might injure the cervical spine better, we go for the Mauritius Belly rather than
MSV technique is
there is a modification of this Burns-Marshall, what is called as brace technique. You hyperflex and abduct the mother's thighs, and then it is the similar. Then you push it cross. It gives you the same result. Okay. Mauritius Melly-White technique. How do you do that?
That is that we have to keep the two hands and the one on the ring finger and then the wrist is like this. Okay. To keep the flexion. I told that the right hand on the either side of the head, and then this right hand finger is at the middle finger on the occiput to keep the head flexion, and then downwards and then upwards.
Okay.
Jaw
Suppose
flexion and
shoulder traction.
shoulder traction.
Pressure also is required.
Okay. Suppose you can't deliver with this, then
Piper's forceps we can apply and see.
so how
Outlet
will
trick forceps is available.
Then somebody has to hold the baby, and then the consultant has to kneel down, and then we have to apply on the right and left plate. That's
right.
Then there's only the
right.
application is towards upwards.
Okay. Anything else? Anybody wants to?
Do you have a Piper's in your institution, Shashikala?
No, madam.
Forceps
That's
outlet.
why. See, you can you can use the low forceps actually. Simpsons or Kedarnath Das,
Wriggly.
that forceps.
Yeah,
Because you have to go a little higher up, no? So you can use the longer forceps, which is used for low forceps application.
I'm sure with the medical legal hassles and the CPA, nobody's doing the elective breech delivery. Most of the times it is
now that in London there is a opti-breech delivery, the trial is going on, ma'am.
Yeah, we're talking about
depending on the patient consent only. That is a thing that
and it is still a trial.
That's the trial. That too, patients are willing then only after taking the informed consent and
So my question,
and they have this thing training for the midwifery and the doctors regularly, and they have a breech trial and all those training they'll give, and then they will take a consent if they'll consent for the ECV also when the patient comes in labor. Then only if the patients are willing, then only. Otherwise,
They have a good algorithm actually, physiological breech algorithm, where they discuss about what needs to be done.
Right from 36 weeks, you should go for ECB. If she denies or fails, then you should offer her the options for planned vaginal delivery or planned cesarean section. You should explain them pros and cons of the both, and then it should be an informed decision making or shared decision making. That is how the protocol goes. But then suppose we want to deliver a patient who has got diagnosed breech. What are the factors you take into consideration, Dr. Srimati? What are the factors you take into consideration that whether she is favorable for breech vaginal delivery?
So, I mean, generally we prefer if it's a multi because we know that it's been a tested pelvis. So previous normal delivery is a very important point. And of course, a term. So we don't want very preterm. So somebody which is term, not a big baby, not a small baby. So usually around, we are looking at around somewhere between 2.5 to maybe 2 to 3.5 they say, but 3.5 might be actually
9 also they say it is very difficult.
for our setting because they say more than 4 kilos, but I think even 3.5 is a big, so reasonable size, no FGR on board. And of course, she coming in spontaneous labor and the breech descending very well. I think those would be favorable, not to have a hyperextension of the head.
Oligohydramnios should not be there. And suspected GDM. That
Type of breech? Weight comes in the weight, yeah. So a reasonable weight term and of course a previous normal delivery, an adequate pelvis and without hyperextension of the head and in spontaneous labor and good progress.
And even in the spontaneous labor also, if the patients are not progressing, they say that induction or augmentation is controversial because they say what in case if the patients that they'll start getting the oxytocin induced contractions are very strong, sometimes it pushes the vertex out, the soft part out, and head get trapped in between.
Yes.
So that's why it's a controversial whether to start the oxytocin or not.
Right.
The type of breech as well.
Andrews score takes into consideration parity, gestational age, estimated fetal weight, previous breech delivery. I don't think previous breech, but we can say previous vaginal delivery, dilatation, and station. So if the score is less than 4, she's straightway for cesarean delivery. I'm sure we are not, following this nowadays. But yes, to be on the safer side, we just try and convince the patient and relatives and go in favor of cesarean section. But I think that is good enough as far as the safety of the patient and yourself is concerned. So,
with all said and done, Dr. Sneha, the very first sentence you told was that it's a gift. I think this is the only time when we do
Yes.
assisted breech delivery in the present day practice with full dilatation, and especially in government hospitals when the OT is not free, we are going to just leave her for a vaginal delivery. And any
I think we
amount of
should
counseling
We
nowadays,
can,
patients
sir.
are
We
not
can, sir.
agreeing for
36 weeks, fully dilated, +1 station, previous
Yes.
vaginal delivery. I think it's.
I said
I think we have to
again
practice
so
vaginal
that,
breech delivery in twins, madam. So
Twins.
the second twin being breech, we
that
should
we have
always
done
practice.
many. That we have
They
done.
say that is the only
comes
breech
for good for you.
extraction can be done in that actually. Breech extraction can be.
Yes, because the passage is all open, welcome for the baby. So definitely. So this is a situation where you can have one breech vaginal delivery at your credit, you know. So this is what the situation is. And of course, we have already discussed about the various types of breech delivery and the various techniques for the after coming head of the breech. So we quickly go to the fourth case now. We have this 34-year-old little elderly second gravida, gestational diabetes mellitus. She comes to you in labor at 37 weeks. On per examination, you have 36 weeks cephalic presentation, little large size baby. Per vaginal examination shows 2 centimeter cervix fully effaced. And of course, the labor progresses well. Within 6 hours, you know, she progresses well. Now, when you examine her per abdominally, 36 weeks, cephalic presentation, head not palpable, fetal heart is good, and she's fully dilated, fully effaced, vertex at perineum. But when she's pushing down, we find that even after 20 minutes of full dilatation and pushing, the head is, you know, not descending further. Head is delivered, just delivered, but the shoulders are struck. What is this condition? How will you tackle this situation?
So good evening, ma'am. I'm Dr. Satya. So I will be taking this case scenario. So like as all of us know, whenever we are unable to deliver the fetal head with the gentle traction that we normally apply, and we are needing additional maneuvers, we would diagnose a shoulder dystocia. Although there is some time said, like, you know, if it is taking more than 60 seconds, then we call it a shoulder dystocia. But whenever we are experiencing a problem delivering the baby and the head is retracting, the face and the chin is retracting against the maternal perineum, and there is no restitution happening of the head, these are the situations where we suspect a shoulder dystocia. So quickly we would examine the mother and see if the shoulders have descended. Ideally, it is usually the anterior shoulder which is impacted against the pubic symphysis. Once this is diagnosed, we have to communicate to the mother and advise her to stop pushing, and we should stop pulling. So once the diagnosis of shoulder dystocia is made, we are all aware that it could lead to serious maternal and fetal consequences. So our management should be very precise and planned, and we have to be quick enough to get the baby out without hypoxia, and also gentle enough so that we don't injure the baby. So once we diagnose, initially we have to call out loud and say that there is a shoulder dystocia and call for help. Usually we call out for a senior obstetrician, the anesthesia team, and of course a pediatrician. And one person should start noting the time, and every time that 30 seconds have elapsed, the person should give out a call so that we are aware how much time has passed. And the other healthcare workers who are there in the labor room should first lower the table. If the head end is elevated, lower the head end. If the mother's stirrups, legs are in the stirrups, loosen them, remove them from the stirrups, and quickly have a footstool for the assistant to help in the delivery of the shoulder. So once all of this has been done, we would now move on to the various maneuvers that have been suggested. So the first and foremost maneuver that we would like to use is the
I'm sure even if you're taking so much time describing, your actions would have been very quick when you're managing.
Yes. So we have to be mindful. Yes, we have to be mindful that we get to deliver the baby within about 4 to 5 minutes so that there is no hypoxic ischemic encephalopathy. And hence we have to be very quick. But then the timer and the documentation becomes very important. So then once we do the macro
burst maneuver. What is the first thing you do? What is the first maneuver you want to do?
So we would go with the macroburst maneuver because that is the most successful and the most easiest, wherein the mother's abdomen, the thighs are flexed and abducted, and so that the sacral hollow just gets flattened, and there is cephalad rotation of the pubic symphysis, which increases the available AP diameter. And this may help in dislodging the shoulder, and we have to give a gentle traction, and the traction, mind you, should be parallel to the spine of the baby. It should not, the baby shouldn't get pulled laterally. This is where the brachial plexus injury comes in. So we have to be very mindful about
we didn't understand where to give the traction.
So once we do the MacRoberts maneuver, we will have to give gentle traction, and also you should have a assistant standing on the side where the back of the baby.
In fact, what the message to be given, they always say that absolutely no traction. It should be suprapubic pressure.
Suprapubic pressure.
Suprapubic pressure.
Dislodge the shoulder can be given along with suprapubic pressure.
Dislodge the shoulder, which is there in the AP diameter, it should come into the oblique diameter.
Oblique diameter, and then we just give gentle traction along the axis of the spine so that the baby can be delivered. Suppose this is not effective, then the current guidelines are suggesting that we proceed with the posterior extraction of arm rather than trying the rotational maneuvers of Rubin's maneuver or the corkscrew maneuver, because it has been said that these rotational maneuvers are associated with more incidence of brachial plexus. So for the extraction of the posterior arm, whichever side is anterior to the baby, that hand of the obstetrician should be inserted into the pelvis, follow the posterior shoulder, try to reach the wrist of the baby, try to flex the elbow, and then the hand has to be swept out of the shoulder along the face, or swept out of the pelvis over the face of the baby.
So it's not easy to do that maneuver.
Yes, definitely, ma'am. It is not.
MacRoberts, diagonally and reposition and go for cesarean section. Or symphysiotomy, if anybody has any experience, they can talk about symphysiotomy.
No, I think posterior arm we could always try. If it is very badly impacted and we are unable to insert the hand into the posterior vagina, then there is a new technique which is called as the posterior axillary string traction. It has been proposed by Professor Hofmeier, wherein we use a suction catheter, which is not elastic. So we shouldn't be using a Foley's catheter. We use a suction catheter, use it as a sling, and thread it into the posterior axilla and use it as a traction to try and deliver the baby. From the literature, it says it has better outcomes with respect to success of delivery and also reduction in the chances of brachial plexus injuries. Then if these things fail, then it is suggested, yes, we should go ahead with the corkscrew maneuver and the Rubin's technique. If in case the mother is small built and she's not on epidural analgesia, etc., then she can be put on force on all fours, and the Gaskins maneuver could be tried. Now again, the Gaskins maneuver, they say, has a success of about 80%, but then it's not possible to do that on everybody. Depends on how the mother is, whether she's on analgesia, etc. So now, once we have tried all this and still we are unable to deliver the baby, then definitely
let me take a moment. Let me take a moment to explain that why we want to go for this MacRoberts maneuver. How does it help? Because when you hyperflex the woman's thighs and abduct the legs, it straightens the birth canal. So it makes the delivery little easy. Nowadays the concept are changing. If you have heard, it's not the supine position for delivery. In fact, the squat. So it is helping you in that way when you are raising the head, and also that is, adding to the descent. It is helping the descent of the baby, and it is straightening the birth canal. It also improves or enlarges the AP diameter. Okay, that is how. And where you should give the suprapubic pressure. See, now the head is out and you can make out where the occiput is. So you have to give the suprapubic pressure on the side of the occiput. If it is on left side, as in this picture, you have to give the suprapubic pressure on the left shoulder, so that that is getting pushed and the bisacromial diameter becomes less. Right? So that is how it helps the delivery of the baby.
The shoulders in AP diameter will occupy the oblique diameter.
Oblique diameter. Also, it helps in adducting the shoulder. So that also can reduce the bisacromial diameter to an extent by giving the inferolateral pressure.
Wood's corkscrew method sounds quite, easy and practical as well. You can see here, because the posterior shoulder has already escaped that obstacle. It's the anterior one. So if you rotate the baby through 180, the anterior becomes now the posterior. So posterior has already escaped and the anterior becomes the posterior. So anterior shoulder also comes at a little lower level, and that is also escaped. That is what the basic principle of this Wood's corkscrew. So do not do what I was talking to you is, do not apply excessive force or traction. That is what the basic principle, and ask for suprapubic pressure, not the fundal pressure. That will worsen the situation.
Madam, one more
Yes.
do not do's, madam.
Don't panic.
Prematurely, we should not apply vacuum, madam.
Yes.
Before full cervical dilatation, if you apply vacuum, then the shoulder dysocias will happen, madam.
Yes. In fact, nowadays they are saying that previously they used to say it as the advantage of the vacuum that you can apply it even for incompletely or near
dilated cervix.
But
incomplete
nowadays,
rotation,
yes,
allow nature for the baby to rotate normally, so that shoulder dysocias can be prevented.
Right.
The vacuum can be applied, but it should not be prematurely pulled. So we should allow the head to descend, rotate along with the traction. So then
when we are dealing with a mother who is a gestational diabetes, and we already know that the baby is a little on the bigger side, we have to be very mindful how the labor is progressing. If there is a delay in the active second stage, there is no descent, we should be careful when we decide for a forceps delivery. Unless we are 100% sure, we shouldn't be attempting any instrumental, especially in a situation where we are suspecting macrosomia and there is a delay in the descent of the head.
And one thing, 50% of the time, there will be no risk factors for the shoulder dystocia. That also should be kept in mind. Without risk factors, it can happen 50% of the time, shoulder dystocia.
Yes.
And then documentation of which arm was the anterior, which arm was the posterior becomes very, very important, because obviously for future, sometimes even the posterior arm could be affected even naturally, even without shoulder dystocia. So I think documentation of which arm was anterior, and of course cord gases and debriefing becomes very important in order to avoid legal issues.
And in the maneuver, that Wood corkscrew maneuver, more than that, posterior shoulder delivery is more practical and quick.
Practical. Yes, ma'am. That is what the literature says.
Yes.
You said some sling, no, Satyaveni?
Yes, ma'am. This is a new concept. It has been, I think Dr. Hofmeyr is doing it in Africa. From 2009, he is practicing this, and he finds it very useful in delivering women where he is unable to, where the macrobursts and the posterior arm is not successful. So here, because we don't have to go deep into the pelvis, we just have to go across and be able to reach the posterior axilla. So we can either use a suction cannula, the infant feeding tube or the infant suction tube, which is always there in the labor room, or the oxygen tube, which is there in the labor room. Just make a loop out of it, and you with one index finger try to hook it and go below the posterior axilla, and with the other index finger we just bring it out so that there is a loop. And using this as traction, they have given a downward traction on the shoulder, which will kind of dislodge the posterior shoulder further, making the posterior extraction easier. They have in the literature, I think there are about 19 cases which they have done, and they have shown that the brachial plexus injury has occurred only in one, that too in the anterior shoulder, because all other maneuvers were already tried, and the brachial plexus injuries are very, very less with this technique. So now I think it is not yet a guideline, because more research needs to be done in that. But the concept is that
shoulder dystocia is a nightmare. You can do the best with the macrobot maneuver. That's the one thing where
that is what I'm going to say, that yes, shoulder dystocia in majority of situations, it is unpredictable. In spite of knowing that the pre-existing or predisposing factors and trying to avoid all the aggravating factors, you may have to face this situation. Still, intelligent anticipation definitely has a role. Of course, if at all you have to face the situation, the skilled supervision, prompt detection, and effective institution of the therapy can prevent the disastrous consequences. Not to forget the communication, time to time communication with the patient and relatives, and of course, documentation of this communication, whatever you have done till now. So with this, we just, close our discussion, and I hope these are all practical cases. We have tried to do justice with the discussion. I'm sure the delegates have been must have been benefited, because obstetrics is not my cup of tea. That is what the younger generation is thinking. We obstetricians, maybe around three decades ago, we are still very passionate about obstetric practice, and of course the various maneuvers and the instrumentation. Definitely, because we are well versed with it. I think what I was a medical teacher as well as I'm a private practitioner. So what I feel that the obstetric population is changing and the demography is changing. The high risk factors are rising. At the same time, the teachings that is happening wherever it may be in the government medical colleges or private medical colleges, the hand holding part is missing. So how our teacher used to actually be there present, and they used to teach us, so that till the time we become expert and we apply it independently. So that point is missing somewhere. That is what we feel, and that's a very reason there is a need for having lots and lots of obstetric workshops where you have hands-on, especially. I think that's a way forward. So with this, I conclude this panel discussion. If at all you have some points to discuss, we can have it later as well.
One thing I want to tell, to
Yeah,
practice obstetrics, you need time.
Yes.
You need time with the patient.
You need to give time.
As I said,
all of us,
all of us
have time.
We cannot rush away with the faster ARM or active intervention during labor, doing ARM and ARMs and augmentations. All should not be done. Allow naturally the women to progress in labor. Progress in labor, take a proper decision regarding the augmentation and doing ARM and giving a time for the baby, like a first stage. When you commit a ARM, you give a time for a primary, at least 6 hours, or for multi 4 hours to dilate fully. Then again in the second stage, from second stage, 2 hours in a primary and 1 hour in a multi to progress to normal delivery of the baby. So we need a time. Every younger budding obstetrician should, when they take this OBG, they should think that I need to practice and have time for the patient, not for us. It's for the time for the patient, what we require for the present generation.
Right. Absolutely fine, madam. In fact, when we plan these programs, for my committee, we usually have 2 talks, and that is the WHO Labor Care Guide. How you should monitor what are the changing concepts in the management, the duration of labor, various stages, even the monitoring, the concepts are going, they're changing very fast as well. And then, of course, the WHO ANC Care Guide. I think right from beginning, what is the important is preparing the woman, not only physically but also psychologically for the labor and delivery. That is also a very significant point as far as today's
encouragement for epidural analgesia, madam. There is no proper analgesia given for a labor patient.
Yeah.
No proper analgesia.
One important thing in labor ward emergencies, so we should have periodic drills. The team rehearsal should happen time to time. Then only our knowledge can come to use in labor room. Otherwise, see, whatever knowledge we have, so unless our team is geared up, so we'll not be able to do much. So that team rehearsal should happen periodically in any institution for that matter.
Madam, one more thing. For induction of labor, you put cerviprimes every 6 hours. It's not mandatory to put cerviprime every 6 hours. You can wait for 24 hours also, 12 to 24 hours also for the next dose of cerviprime. That should be practiced. No saying that failure of induction. You have seen so many indications, cesarean section indications, failure of induction. It's not right.
Failure of induction, you can say when you have already applied 3 doses of cerviprime, that is dinoprostone.
Time interval, second dose, 6 hours, they put. You can give an option of 24 hours also to have a normal delivery.
Definitely. When you don't have any hurry, definitely.
That is the reason we should have protocol-based management in every institution. It should be uniform protocol, so followed through the department. So that will help to standardize the practice.
Yeah. So yesterday I have moderated a panel discussion on induction of labor for ICOG. The labor course is going on, no?
Yeah.
So there actually the protocol says either 3 doses of dinoprostone, that is 6 to 8 hourly, that is 1.5 milligram, or the PG even tablets, no, misoprostol tablets, that is at least give it over 4 to 6 hourly, 25 microgram. And that too, you can give it even 4 to 6 tablets that you can give. And then the Cervidil, that is the cervical insert, vaginal insert, no? That also you can use nowadays. It's quite effective. Even I have used it for 2 patients.
One more point: augmentation of the labor with oxytocin should not be done without effacement.
Definitely.
You start off with the
I mean, I would say that it's not even a augmentation. If the cervix is not effaced or right properly, she's even inducible.
Yeah.
Right. So
make it properly. Good Bishop score should be there.
Yes. Yes.
Then only you should commit yourself.
Yeah. So thank you so much once again, everybody. And I just take this opportunity to humbly appeal for my candidature. If you feel I deserve, please do vote for me and vote in large numbers. This is for the Foxy Vice President from West Zone, and the elections are in August. You may have, we may have, because West Zone is the hottest zone, you may have 5-6 candidates from West Zone, but please do consider Dr. Sneha Buyar and please do vote for me.
Wish you all the best.
Wish you good luck, madam.
Thank you. Thank you so much.
Dr. Shailaja.
Thank
Dr.
you. It was wonderful moderation.
Thank you, Dr.
Kala, madam. Thank you so much for
Srimati. Yeah. Thank you, everybody, from the bottom of my heart. Thank
Dr.
you.
Satyavani and all the BSOGs. Thanks for accepting our invitation.
Thank you.
so much for the
Thank you.
opportunity, madam.
Yeah. Thank you. Thank you.
Thank you, Dr. Rekha, and thank you, Dr. Sneha. Aruna here.
Thank you, Dr. Aruna. It was wonderful.
Yeah, it was absolutely wonderful. Thank you so much. And you look so pretty and you look really radiant, I must say.
Thank you so much. Thank you, madam.
Bye-bye.
So, bye-bye. Bye. Thank you,
Bye.
Dr. Rekha and the BSOG. Thank you, all the esteemed faculties. And thank you so much, all the delegates, for being here till the late time. Thank you so much.
Thank you. Thank you, ma'am.
Yeah.
Thank
Bye-bye.
you for the flawless program. Thank you.
Thank you, Rekha.
Yeah, thanks, Rajni. Thank you so much. I'm seeing here only, not physically.